I will say, guys, jump in at any time if you have questions. Like, I don't even mind if you interrupt me. I know I took Sloptimal last weekend from Scott Morrison, which was awesome. And it was on Zoom. And sometimes like you want to ask a question, but you can't see you. And so I'm not going to be able to see y'all probably. So just be like, hey, Taylor, and just straight up interrupt me. That's fine.
It's going to be like the most therapeutic journal club because we got the little birds in the background. That's great.
Can you hear them? I like put in my earbuds to try and minimize background noise. So the birds are pretty loud.
Yeah, they're getting pretty stoked.
Yeah.
Okay, so I think there's a few people here that weren't on last week. So I'll just give like a little intro. So I started this journal club maybe like 8 months ago when I was a first year. And it was mainly just students in my cohort. We talked on Fridays, and then once COVID happened, moved everything online and started getting other like students and clinicians just interested and wanted to join in the party. So now that's where we're at. Taylor, do you want to give like a brief little background about yourself?
Yeah, so I just graduated from George Fox University in Oregon in May. Before I went to PT school, I was an aide for a long time at a lot of different clinics. I started my first job as a PT aide in high school, actually. So I've been pretty consistently in the field in some capacity for 12 years now. Have also worked as a personal trainer, strength coach, done some more performance-oriented ortho clinicals. And then if you were around earlier, I'll be starting at a ortho clinic in Portland, Oregon next week. So that's kind of me, where I'm at. I love getting to spitball about stuff like this, though. So thanks, Chris.
Yeah. And so for our journal club, we've been doing like monthly topics. And so Taylor's going to be kind of rounding out this last month on, it's kind of been like a fluctuating topic, but pretty much like resistance training and strength and conditioning. And normally we are looking at like 1 or 2 journal articles, but when Taylor and I kind of discussed, it made a lot of sense to kind of just have more of an overarching discussion and kind of Taylor share her model. And then we discuss kind of how she sees progressions, regressions, and loading. And it may be easier than looking at a paper. And then next month's topic, we voted on the GroupMe, and it's going to be motivational interviewing and behavior change. So that will be starting next week, and we'll figure out kind of what the dealio is. But yeah, Taylor's going to crush it. And I'm going to share my screen because she's got a slide deck. Let's see. Can you all see my screen? Yeah.
Yeah, and I will say, you guys, like, this is not a fancy presentation by any means. It's more that I didn't make it available ahead of time because I want it to serve more of as a conversation starter and less of something that you're just glued to. So I would encourage you, if there's something that you've never heard of before, like jot that down to the side. And then if there are things that you're like, oh, this is familiar, but I've never thought of it that way, like just take some little notes on that. And then I'm happy to send this out later or provide references, that sort of thing. All right, so next one, Chris. Starting out, my favorite thing ever is the SAID principle. Hopefully you guys have encountered this at some point. And I think that this is a really helpful starting point, right? Because everything that we do in clinic, hopefully, is driving some sort of adaptation, whether that's driving an adaptation that we're getting a physiologic response from the stimulus we're applying, or maybe we're working on improving tolerance, something more like graded exposure. So the way we're going to look at exercise selection today is in the context of compound movements versus isolation exercises. And they both have, and just thinking through what are some variables that we can manipulate then within a particular exercise to manipulate the demand that we're applying in order to drive adaptation. All right, next. All right, can I see this? I'm like, sorry, I'm really close to the screen so I can read my own thing. This is actually a slide I pulled from a different talk I had given, but I think this is really helpful to think through what does the athlete or the patient in front of you need before you start getting after exercises. Because sometimes it can be easy to think, especially as a new clinician or a student, oh, they're a knee patient, they should do X, Y, and Z. Or, oh, they have a hip issue or a cuff issue or this, that, the other. And then you like jump to this set of exercises that maybe in Therex or whatever learned applied to a particular situation. I think instead of breaking it down and kind of zooming out, okay, do they need range of motion? If so, is there deficiency in passive or active? Okay, that will help drive exercise selection, right? In their ability to express force, what context do they need to be able to express force in? Is it something that will vary a lot throughout like a given task, or is it something that is going to be very repetitive and has to be done a certain way? So that might be the difference between someone who does manual labor versus someone who is training for sport. So when in doubt, you just ask questions about that. And then the other factor is, do they need to be able to express force quickly? I think most humans at any phase in life will be able to benefit from being able to express force quickly. But that makes something that you have capacity to assess in your clinic, or you might not have the capacity to objectively assess it. But say even if it's an older person who's working on fall prevention things, that's going to be a big component. Quick note there, the reason I talk about expressing force versus do they need strength is I think strength is a tricky term that you could get down a rabbit hole trying to define. If you want to dive into a more nuanced discussion of that, Eric Mera goes into that on the Clinical Athlete podcast, but I will save you that soapbox for another day. Energy systems development, some people might call that like your conditioning or your cardio. And it totally just depends on your person, right? So if you've got, let's say, a high school athlete who is initially post-op, but maybe they can't do much high intensity work, but they could do some like low intensity, long duration. And maybe that's just them saying like they're in their boots still or whatever. And you're like, hey, if it's okay with your mom or if it's okay with your schedule, like you can stay an extra 30 minutes after your appointment and do some cardio on the bike on your own or whatever. Or maybe it is specific. I also highlighted here, sometimes goals from a training perspective will not be specific from the patient's perspective, right? And in that case, maybe for them, setting process goals might be more attainable. So for example, I see this a lot in middle-aged to older women, they don't care about being strong. Like they just really don't. And that's a good segue to the next point of like, what if your goals don't match theirs? Is like, my goal for a lot of those women is to get them stronger, and that's not their goal. They just want to be out of pain. And so it's your job as the clinician to learn how to nuance those discussions, to be able to meet them where they're at, and also help them reach a point of understanding, okay, maybe this has some benefit to me in my situation. Any questions there before we go on? That was a lot really fast. Okay, holler out later. Next. So here we're thinking about compound movements, right? Our multi-joint exercises. And usually people break these down into, squat, hinge, push, pull, carry. Some people will add rotation. And then I further broke it down and I consolidated squat and hinge because I think, especially if you don't have a background in resistance training, it can be really helpful to think of these as a continuum. And I've got a picture to illustrate this in a little bit coming up. And within the squat and the hinge, that would also capture the lunge and the step up. And I think anybody who's ever gone upstairs knows, you can walk up the stairs really upright, right? Or if maybe you're doing step ups on a high box, are you going to stay super upright? No, you're going to really hinge from your hip forward, right? Get more trunk flexion or more hip flexion, right? As your trunk leans forward, and that would push it more towards the hinge end of the continuum. So all that means is, are we biasing the exercise more towards the quads or more towards the posterior chain in terms of the movement pattern? So like a deadlift, depending on the person, can kind of be in the middle, right? Like an RDL would be far to the end of the hinge spectrum versus maybe a conventional trap bar deadlift is going to, from high handles, will look a little bit more squatty. Or you could even cue someone to do it in a more squatty sort of way if that is your goal. Push and pull exists on a continuum of vertical to horizontal, so that should be pretty intuitive there. And then carry, you can meet a lot of different needs with that, whether you're doing unilateral versus bilateral by somebody's side, kind of waiter position, 90-90 overhead. Lots of options there just based on what your goal is for that person. And then rotation, I put concentric versus isometric, thinking like, say a med vol throw versus a Pallof press. But you could also argue that rotation work could be isotonic or it could be eccentric only, right? If I'm throwing the medicine ball to you and you are decelerating it in the transverse plane, then that would be eccentric only. So just some options. Does that make sense to everybody? Thumbs up. I can't see. All right, next. So isolation movements, I think sometimes get a bad rap, especially when people like get hung up on this idea of being functional, whatever the heck that means. And I think sometimes people will make the argument, oh, I do functional things, or, oh, like those silly PT exercises don't do anything. Well, actually, if you think about it, if you've had rotator cuff surgery and have not been allowed to externally rotate your arm for 8 weeks, you probably need to isolate your rotator cuff. Pressing alone probably isn't going to load those tissues very specifically. Another example would be leg extension, right? Like I'm a perfect example of this. I have had issues with my left knee since a surgery in 2008 that wasn't rehabbed very well. And so I still have a pretty big deficit side to side in terms of my peak extension force. And some people would say like, oh, but you can do heavy squats, like you're fine. It's like, well, no, I'm just not using my left quad as much as I could be. And so doing a leg extension constrains the environment so that I have to use my quad and I don't have any other movement strategies that will accomplish the task. Lateral hip, like maybe if you have, somebody with gluteal tendinopathy, yeah, it's great to do compound movements, but if you really want to be putting load through that structure, you have to make sure that they can't compensate away from it. And then I also put wrist extension on there. That's a pretty common one for like your lateral epicondylitis, that sort of thing. So next slide, I believe, is a picture.
Taylor, I have a question real quick.
Yeah.
And maybe we'll get into it later, but with like some of the examples of maybe the ACL post-op and looking at kind of the limb symmetry of quad index for like leg extensions, once they reach like a percentage ratio that you think's doable for kind of progressing, what are your thoughts on keeping in those type of like more isolation movements, or do you think that like the end goal still needs to be they don't need them once they have kind of enough kind of symmetry on both sides?
I think it would depend on the person. I mean, I think if you're at 95% limb symmetry, do you need to keep working on it? Probably not if you're playing your sport. Although I would say my question would be, why wouldn't you? Would be my question. It's, one exercise, you could do it once a week. Even if you did like a round of myo reps once a week would maintain a training effect. For those of you who don't know, myo reps is doing, roughly like picking a weight where you'll hit your 12 to 20 rep max, somewhere in that range. And then you rest like 3 to 5 breaths and do another set to failure, and keep resting 3 to 5 breaths and doing a set to failure until you can't hit the number of reps you did on your second set. So sometimes it'll go like, 14 reps, and then it'll be like 6, 6, 6, 5, and then you're done. But I would just say, why wouldn't you? Now, if it's somebody who has a cuff repair and it's one of those patients where you're like, why on earth did they operate on them? They were fine beforehand and they're not super physically active, and you get them back to good enough, as long as they're doing some sort of general strengthening, they're probably fine. If you're an athlete that's going to be strength training anyway, I'd kind of be like, well, why wouldn't you work on your quads?
If I might be able to add a little bit of that as well, I think
yeah.
And post-op ACL, especially like once you start getting into more close chain movements, squats, lunges, and things like that. Although I think those can be taxing movements. A lot of times, like you were saying, you can have people who definitely use different types of strategies and may have a little bit more like glute dominant or hamstring dominant activity. And so I think by even in the later stages, as they get 5, 6, 7, 8 months out, still implementing those leg extensions just so you can really induce a little bit more fatigue to continue to progress strength and hypertrophy. I think it's like the most specific exercise you can do to really target that quad muscle.
Yeah, who said that? That was a great point.
I'm sorry, that was me, Alex. I'm on, I have my video off because I was helping a friend move and I'm like really sway looking.
Oh, you're fine. I mean, I just spent 2 nights in the wilderness. But yeah, no, I totally agree with that. And I would even argue too, just because they're moving the weight, unless you have them on force plates, you don't really know if they're loading each leg evenly. So are they training a compensatory pattern that looks good? Or are they, yeah. So I agree with that. Next slide will actually be that's a good segue into the next slide.
Can I ask a question real quick?
Yeah.
Okay, this is Travis, by the way. If let's say you achieve 90 or 95% limb symmetry with your isolated single or like unilateral exercises, if you went away from those, would you expect the symmetry to kind of go in the reverse direction once you go to bilateral exercises? Or like, is that one reason to keep it in, just to maintain that? Or do you think like there's reason independent of any injury to include unilateral isolation training? But in the particular case of like an ACL rehab where you've achieved the symmetry, and then if you went away from those things and just did bilateral, would you feel like there's a chance that the person could regress back under 90 or 85 or whatever your threshold is?
Yeah, I think it would totally depend on the person. You know, if it's somebody, and you'll see this in clinic with kids, especially girls, sometimes some of them just are not confident loading into that knee. Say even a single leg deceleration task, they go full on hip strategy to avoid it. And that would be somebody where if I hit 95% limb symmetry, but you still move like you have a deficit, that would be somebody who would definitely want to keep loading them in that way, because I know they're not going to be exposed to loads that maybe would help keep them there. Versus if it's somebody who, maybe the whole time you've been like, oh, whoa, early on, it's like, let's not get their knees so far over your toes to minimize strain on the graft initially while it's healing, and they're super comfortable loading into that limb in a very knee dominant way, then I think that would be somebody that I would make the case like, oh yeah, it's probably not as important. But yeah, I agree with you, irrespective of injury, there's still benefit to it. And ultimately you don't know if you're losing it or not unless you retest. All right. Good way of thinking about that hinge continuum. That oval, anything that counts as a lunge, and then that numerically plotting how much the hip contributes, how much the knee contributes, and if you can see, is it on the next slide? Because it should be. So anything within the circle and those dotted lines counts as a lunge, right? So you might have an instance where a person is not exerting enough force or expressing enough force in order for it to be a lunge, right? Maybe they're just doing this like funny little like dippy bob thing. And then you've got on the other end of the continuum, maybe, there's a point of diminishing returns, right? Where you can bias the lunge as much as you want towards the hip, but ultimately there comes a point where if you're not using your knee, it's not going to be a lunge anymore, right? So we think of that as those are the constraints that count as that particular task. We can see how there's a lot of various ways this can be successful. I think that is a really good question to ask. Is the goal being able to do the task, or is the goal being able to task utilizing resources? And this is where I think that really comes back to the patient, right? People get up off the floor when I'm playing with my kids. I'm using versus what percentage hip I'm using? Probably not. My goal is to load the quads. We're definitely going to want to buy it a particular way. And I just was in looking at this. I might have done I think I did the graph backwards. That was dumb. That green line should be flipped the other way. This is not looking right. Should be flipped. That's the type. It should be oriented this direction as those dotted lines, and the oval, I bet you guys. Does that make sense though? The idea of you can have a spectrum of how different forces contribute. Cool, next slide. I have to fix that. Okay. just a little bit of a plug here. If you guys haven't encountered this in your own, either in your education or in your own time and reading, this graph comes from I think 29 paper from Guccione. I don't know how you say his name. He's out of George Mason University. It was in, I think it was in JOSPT, and it was essentially critiquing the movement systems through the lens of dynamical systems theory. And so you have this nice little graph here that is a great way of conceptualizing how movement emerges as the complex interaction between multiple components, right? So you have your task, that would be the lunge. You have the environment, right? Where are you doing your lunge? Getting up in the living room, you have with your kids versus say in your garden where it's a really uneven surface. The organism that includes, are you afraid to do a lunge up off the ground, or how much hip are you using versus how much knee are you using? And all those components interact, and then from there is where the movement emerges, and we see a lunge that might be, I think, go to the next slide, Chris. There we go. That it could look two different ways, right? Those are both split squats, rear foot elevated split squats in this case, but the movement has emerged in two really different ways. And then I just drew a little, the purple line is your ground reaction force coming from the foot through the center of mass roughly. And you can see the green moment arm of the external knee flexion torque can be manipulated, and it's the same for the blue hip moment, right? Depending on that trunk position. So moment arms are a great starting point for thinking about how you can manipulate variables within an exercise to accomplish a particular task, whether it is, okay, we're going to manipulate this to make it easier, right? If somebody can't do it, say they don't have very strong quads, but you want them to be able to do a split squat, it could look more like the picture on the right side of the screen. If you want to really limit them, limit their ability to use their hip, it looks like, thanks Shelby. Yeah. E3 Rehab, by the way, you guys, shout out to them. They have really great information. I'm not gonna keep up with the chat. I can't see it all on my phone, but yes. And then you can also bias it towards the quads. Now, that's talking about within the organism, right? If we talk about the environment, we can manipulate that by where we load, right? So we can load in front in the goblet position to help bias the movement towards the goal, or we can load, in this case, I believe it's like unilateral, suitcase hold, whatever you want to call that, to help bias it towards the hinge. Does that make sense? Another really simple way you can manipulate the moment arm, a great example would be a Copenhagen plank, which is where you do a plank that focuses on the adductor of the top leg. So the plank is braced with the top foot, usually on a bench or something like that, and then you lift up and the bottom leg is more or less uninvolved. For a lot of people, that can be really difficult at first. So you might manipulate that so that you're doing a shorter lever Copenhagen, right? So you would just move the bench closer to the person's hips. And that would be another way you could manipulate a moment arm. I'm curious, you say out loud, this is a rhetorical question, but did you put manipulating a moment arm as one of your options? Good food for thought. All right, next. Counterbalance is another way that we're, again, manipulating the moment arms. In this case, I was doing it with a Cossack squat, but you could do it with a regular squat. And I found as I was going through, thinking through this presentation, sometimes it's easy to, it can be difficult to conceptualize, how do I do that? So I just tried to put a lot of pictures in the rest of the presentation. And this would be a way that you could manipulate a movement. And then, this could be a progression or a regression, right? Depending on the person. So if they've been, say, doing weight shifts, at the plinth, and they're starting to get a little deeper, maybe them holding onto a post, or in this case, you're adding a counterbalance, is a progression, right? It allows them to progress their range of motion beyond what they could do without the counterbalance. For other people, it might be, they're coming in, they've been doing Cossack squats, holding a kettlebell, straight down in front of them, and they come in and they're sore or they're flared up, and this would be a regression. I think that's really helpful to always frame things in terms of the context, right? So that you're not memorizing, oh, a counterbalance is a progression or a regression. It's either or. It just depends what the baseline is. Does that make sense? I don't have a picture of this next one, but in the same way, I think it's not that, we're not there yet. Yeah, and I'm just gonna talk about it. In the same way, reducing or increasing range of motion can be a progression or a regression. And what I mean by that is a great example. Think of like a box squat or a sit to stand, right? So for some people, if they're really struggling, you might add the box as a regression. For other people, you might progress to doing their squats to a box, but loading them heavier, in which case you could argue it's a progression. You could also just manipulate the height of the box to either progress or regress based on the goals. So I think it can be really helpful to remember there are a lot of variables that you can change, but the same change can be used in different ways. That makes sense? Now we can look at the next one. So we got 4 different ways to do rows here. And I think I want somebody to just holler out, let's take the first picture, so at the top, right, that bilateral chest supported row. That again, that could be a progression, right? If we're really like starting to push weight, and by giving someone a little bit more proximal stability, I hate that phrase, but it makes sense here. But giving more proximal stability, or in this, we're manipulating the environment, right, to constrain me, the organism, to not be able to use as much like hip or spine torque here. They could be a progression or a regression, right? It could also be maybe a really easy entry point for someone to start rowing without having to worry about like, what's my back doing? So I want you guys to think through, give me a reason why you would prefer to do a row with more degrees of freedom. So like one of the bottom 3 pictures, and then give me a clinical reason where you would prefer to do a row with less degrees of freedom. So maybe either the chest supported or even the 3-point row. Just holler it
out. So this is Kevin. I was just going to say that this kind of goes back to the constraints in isolation, that as you're taking more of the movement adaptations, you're limiting those. You just become more specific. So kind of like what you were saying, you can be, I guess you have a better idea of what's being loaded with more of the movement being constrained.
Yeah, that's a great point. Anybody else?
Maybe the person doesn't have, maybe the person doesn't have a good enough hip hinge to do a bent over row, or maybe their hips are so deconditioned that that's where they feel it before they feel the stimulus in the lat or retractors that you're trying to hit. So that would be a reason not to do the bent over row.
Yeah, absolutely. Anybody can think of a reason why you might want to give somebody like that single arm unsupported bent over row?
Well, I used this in the clinic, and I actually progressed from kind of that top picture, I guess, I don't know if you'd call that a seal row or whatever you want to call it, with someone who was having some back issues and was scared to have hip flexion bend over. And then we progressed all the way over to, we didn't do single arm, but we progressed to a double arm bilateral bent hip row. And it was more, I would say, more of a mental win for them to be in that position in row versus maybe the actual benefit of the different variation with shoulder extension and, back, just the muscle in your posterior back. But I think it was more so, wow, I can get in this position and it's a huge win for me.
Yeah, I love that example. And I think that's a great way of illustrating, maybe in that case, the adaptation that you were going through wasn't physiologic. Maybe it was just that building that tolerance, that confidence. I think that also brings up then the point that if your goal is to create physiologic adaptation, you want to do so in a way that you actually can load it enough, right? So like me doing single arm bent over row, at some point it hit that in returns where maybe I could row more weight, but so much of my energy is going to try and stabilize my trunk that I'm missing out on rowing intensity, so to speak. Whereas even just the 3-point row, suddenly I can push the intensity, push the weight a lot more. Whereas if you have something like a bird dog row, which I think is that picture is probably like 3 years old at least. I like went into the depths of my Instagram to find it. But I feel like that's one that people are like, oh, it's such a great exercise. It's so, blah, 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 so many things. I'm kind of like, maybe it is for signs, maybe it is for somebody who does yoga and I don't know, the wrong is position. I don't know. But I think it's something that looks a lot cooler than maybe it actually is. Or that could be a great thing, if somebody was doing bird dogs, say they come in and they have low back pain and they're like, oh yeah, I did PT before, it was really helpful, and they had me do bird dogs. Maybe for them, that's a way that you honor their preference a little harder, but also knowing that harder doesn't necessarily mean better adaptation. So I like this because it shows the way a particular exercise can be manipulated just based on what the person needs. Any questions there or other follow-up comments, how you might have used a similar progression in clinic?
Yeah, Taylor, I like
go ahead. Yeah.
Single arm bent over row for any kind of like anti-rotation work. Whether that's ACL, just trying to work in like more trunk stability or stiffness or whatever you want to term it. Yeah,
absolutely. And even that chest supported version at the top, you can do, in a clinic where maybe you don't have as many resources, somebody just prone on the table, affected side off the table, and they're rowing, and maybe they're even rowing if they're holding 2 dumbbells because you don't have the option to go heavy. That's a way you can constrain it, though, that you can really drive the adaptation that you want, which in that case would be that traction strength. Anybody else?
Yeah, I mean, when I was a personal trainer, the chest supported row was gold because it's like, as you said, it's like a self-teaching tool. There's only like almost one way to do it because you don't have much body momentum, or even like if you're talking about like a vertical pull, like a short seated pull down or something, like when you're on the floor and you really can't like use a lot of torso momentum, some of those things, it's like you take away the need for you to keep cueing because they inherently don't have that many options. So I really like that perspective as well.
Yeah. A great example of that too would be like a Z press, right? Or even just seated on a bench, seated on a flat bench overhead pressing. It's a lot harder to contort yourself when you start locking in the lower body. And then it kind of does your job in a sense. And it also makes it nice for the patient because then they're not overwhelmed with a ton of verbal input. All right, next. Joint position. This is a funny picture. I was teaching my roommate the other day how to use a band, like from my pull-up bar, to do band-assisted push-ups. And I wanted to show her just another option. Now, some people might like to do push-ups. She's on the left, I'm on the right. Some people might like to do their push-ups really wide like that, or they might like to do a floor press from that really wide position. Some people might not. And so manipulating the joint position within a given exercise is one way that you can, some people might use the term lateralize or troubleshoot a particular exercise without changing the external load. In this case, the external load being like a negative load, I guess, like the band, right? But in the case of pressing from the floor, maybe it's seen without having to go lighter. So that gets back to the idea of, is the goal to perform the task a specific way, or is the goal just to generally perform the task? And if the goal is a general, increased capacity or tolerance for force, then maybe the way it's performed doesn't matter so much. Instead of cueing them a certain way, say, hey, do a couple. Okay, now do a couple like this and tell me which one you like better. And that involves them a little bit in the process and helps them start to realize, oh, I can move in multiple ways and I can choose how I move, if that makes sense. All right, next. All right, but I saw it on Instagram. There are so many exercises on Instagram. Do this for that, do this for that. And that's great. It can be a really good resource. And I put 2 on here that I actually really like. Just to illustrate, I'm not like hating on it entirely. You know, I like a psoas march with one hip in extension. That can be a really helpful tool for somebody, whether they just because of their injury haven't been able to get into that position, or if maybe they're rehabbing a hip flexor strain, or even if you're training somebody gen pop and they want some novel bullshit to do. It's not easy. So cool. So I think there's an argument that sometimes there's not anything wrong with giving a person something new just for the sake of keeping them engaged. The other exercise is that like short lever side plank with some little horizontal adduction. Again, is this a huge bang for your buck exercise? Probably not, right? Because the more components, the more things that are, the more qualities you're training in one position, the harder it is to push intensity in one particular area, right? So like, yes, I'm getting some stimulus to my left lateral hip and my left shoulder and my right shoulder, but I'm not going to be able to perform high intensity. But is there any benefit to doing a short lever plank while I do my shoulder adduction versus laying on the bench and doing it? Probably not a huge difference. But again, sometimes just keeping somebody engaged, and some people really buy into the it feels hard. And so I think that can just be a judgment call. Any questions about that?
No, I think that's a good point, Taylor. Thanks.
Yeah. So before we go on then, I think that's a great point. I would love to hear from those 3. Can I see what the next slide is, Chris? Sorry. Oh yeah. Okay, we'll keep going and then we'll get to my other point. I just threw this in there because I think this is a great example of how just because an exercise is intended one way doesn't mean you have to use it the way maybe the person you learned it from intended it. So some people will say that, you know, by adding a band like this, it's RNT and you're essentially in order to push the knee out. I don't have any trouble with my knee collapse do a freaking lunge. This is also an old picture, which is kind of funny. But for whatever reason, I wanted to get a little bit more load to my lateral hip. You know, maybe I was doing some higher volume work and I want to build capacity there. Is there anything wrong with adding a band to do that? Absolutely not. Is there anything wrong with, you know, maybe you have that older lady that's working on her lunges and you're adding a band to force her to use muscles that you're not sure if she uses otherwise? That totally works. Or maybe you are doing it just as a tool to help somebody say, hey, rip the band, break the band, and then you don't have to tell them, don't let your knees cave in. So I think there are lots of different reasons you could use a particular exercise, and it might just not be the reason somebody tells you would do it, right? So I think that could be really helpful. Thought experiment is if you learn an exercise and somebody's like, oh, it's great for this very specific thing. You kind of think in the back of your mind, well, what structures is it loading? What constraints is it providing? So what goals could it be helpful towards? So can anybody think of an upper body version of that?
Well, I just had a comment about this, and like I'd love to hear your thoughts on it. And like maybe not this specific thing, but when you start adding variation or adding bands and whatever else you want to do to exercises, do you think that starts walking down that steep rabbit hole of harder but maybe not better adaptation wise?
I think it totally depends on the person in front of you, right? Like if my goal is to have somebody be really strong in a split squat, me adding bands probably isn't going to get them there, right? I definitely think it limits your ability to progress, right? Because most people aren't going to go above the red rogue band. Like maybe they'll get to like a black or purple, but probably not even a purple, right? So it definitely limits your ability to load that particular way. But if somebody's doing, you know, oxidative 30 seconds on, 30 seconds off, that thing's gonna probably freaking burn for a long time. And again, is it harder? Isn't necessarily better, but if you're applying the load in a way that is specific to a goal, that's kind of where I come from. But yeah, I agree with you. It could be a rabbit hole of, oh, you shouldn't just add it to make it harder, right? It should be, I wonder if this person is really just like not engaging their lateral hip, or like I've seen a lot of people that will get like really crampy TFLs when they even try and do like a lateral banded walk, right? Because they just, for whatever reason, their body defaults towards a very TFL dominant way of moving. Probably not anything wrong inherently with that pattern, but if you want to give them more options, making them use their lateral hip for something sometimes is enough that then their body can be like, oh, I can self-organize in other ways, and then they don't get the crampy TFLs. So like that's just kind of an example of where I might use it for. Does that make sense? I can't hear you suddenly. All right, thumbs
Yeah,
up.
it does. Sorry.
Oh, that's okay. Anybody have any other thoughts on this, or on a way you could do this with the upper body?
This would still be a lower body exercise, but you could put the band around your upper back in a squat. So the RNT is pulling you into flexion and you're, you know, maintaining thoracic extension. Still a lower body exercise, but the band is at least around your upper body.
Yeah, another lower body I love is when the band is around the barbell, like an empty barbell or lightweight, pulling forward, and forces you to like keep your lats engaged and keep the bar close to you. As an upper body exercise, there are a bunch of different variations you can do with this. My favorite is where you get that isometric loading pulling you into internal rotation, right? So imagine I'm going to do, you know, the classic band external rotation. I'm, you know, shoulders in neutral, bands pulling towards internal rotation, but then instead of me concentrically externally rotating, maybe I'm pressing forward with my arm and, you know, extending my elbow. Maybe I'm pressing straight up. And I really like that for people, especially in those lower ranges. You know, if somebody has had maybe a traumatic shoulder dislocation and they can't get a ton of external rotation yet, or definitely not external rotation and abduction, you can fire up their cuff muscle, right, with that band pulling across their body while they do, you know, work in neutral, and they're, you know, accumulating some capacity and still selectively loading the rotator cuff without having to change their joint position in regards to rotation. Can everybody picture that? Cool. Next. What about end range? So, right, I mentioned earlier, decreasing range of motion isn't always a regression. This is just a nice little review, reminding us why end range is weaker, essentially. And the reason I put this in here is because sometimes people get all hung up about training your end range and blah, blah, blah. And there's a time and a place for that. But I think it's helpful to remember that you're not supposed to be as strong in end range as you are mid range, because you're at a mechanical advantage. So if you choose to train someone in end range, that's fine. But I think just remembering kind of the why behind what you're doing, right? If they're an overhead athlete that needs to have a high capacity for being in that position, absolutely. If there's somebody, you know, maybe post-op who really has trouble expressing force in end range, and to the point where it's limiting their range of motion, you know, maybe some little end range liftoffs is a great option. But again, I think just remembering, just because there might be a buzz about, you know, end range isometrics on Instagram or wherever, like, you have to always ask, like, what would I be hoping to gain from doing that? All right, next. That might be the last one. I can't remember.
Yeah, I think that's the last one.
Okay, cool. Would you mind pulling up that little worksheet that I sent you guys? Beautiful. Travis says. Oh, cool. Great resource from Travis. Did anybody have a chance to go through this and they want to talk through? I mean, I think it could be fun to talk through the first one, but I think the little case study is probably where we will get more, and then the progression regression will be where we can get more bang from our buck. So let's just dive in with that first case study. Does anybody want to share what they would pick and why? Or if you didn't do it ahead of time, read it and pretend like you're in clinic and do it on the fly now. And all these are real patients, by the way.
What's an ORIF?
ORIF, open reduction, internal fixation.
Got it.
So he has some hardware in his hip.
So one thing that I commonly like to use with people who present with tendinopathy is modifying the tempo and kind of slowing the movement down. It seems like a lot of times it's pretty reactive with like more quick movements. And so a lot of times we'll just use heavy, slow resistance to help with that sort of thing.
So what would you pick for the heavy, slow resistance exercise for a patellar tendinopathy?
Probably like a loaded, slow tempo, maybe eccentric squat with the heels elevated so that it kind of puts a little bit more strain on, or a little bit more stress onto the quad muscle.
Yeah.
And then kind of loading it using intensity that's controllable, or that using an intensity that doesn't overdo their symptoms, that they can kind of still keep within that tolerable range.
Yeah. The only thing I would push back there would be making sure that you're getting them to at least about 70% 1RM, or else the tendon's probably not getting benefit. I've definitely seen people do like the heavy slow load, and they're doing like 15 reps at a 303 tempo, and you're like, nobody can do that for 70%, or if you can, you probably need to recalculate. But yeah, absolutely, that's a great starting point. What would you do for his hip?
It's a good question. Probably sideline planks or side plank.
Yeah.
To start with and see how he tolerates that. Although if he's getting the pain with jumping and running, eventually it probably need more like reactive load, I would think.
Although it's his hip that is opposite the knee that hurts. Yeah, so at that point you might want to just bring it up. A short lever side plank, or like you could call it your raise, where you start on the ground and do it for reps instead of an isometric hold. I think you could make a case for either of those, and then progressing to a longer lever. But yeah, he could barely even hold the side plank on his right side. It was crazy. Super interesting. Yeah, and definitely for him, I think you can see in there, yeah, his peak strength was good, but his power wasn't. So we did single leg extensions fast to start working on that deficit.
So a question about this: if the tempo of the exercise is usually what's provocative, was there any issue with doing the faster tempo on those leg extensions, or was that like a constrained exercise enough that didn't bother him?
I think what we started with him was doing it in a pain-free range, if I'm remembering correctly, and then just progressed until he could get full range at, I think, because we had tested his 1 rep max on the leg extension, and we also had the handheld dynamometry for that. So I think we started him at maybe like 60% of his 1RM and did it like through a shorter, less painful arc, and then progressed the range of the arc. And then also just for him dialing back the running and jumping and starting to work on some force absorption, like snap downs, right? Or 2 to 1.
What actually, how did you measure the power as 75%?
So for him, we used it was leg extension, but it was a Kaiser. So it just gave you the power output. So we just did 5 reps. We found the 1 RM and then dropped it to 80% of the 1 RM. That's just what that clinic does as their protocol. So at 80% 1 RM, 5 reps as fast as you can.
Very
Was
cool.
it 80% 1 RM or 80% 5 RM? See, I'm stuck on that. I don't remember. But it was a percentage of their 1 or 5 rep max, and then that gives you a reading, so it's objective. I think you can also set that up with, like, if you have a cable Kaiser, you can definitely set that up, but that's kind of a proxy for rate. I mean, you're really not going to get rate unless you have, I think you can do it for force plates. I'm not positive, but I know an isokinetic dynamometer you definitely can, but we didn't have that.
Taylor,
All right.
this is like a side
Oh, go ahead.
question, but with
Mhm.
Kaisers, with like any air pneumatic things, I'm assuming you use that at Exos. I don't know what other clinics
Yeah.
where you were, but like,
This was at Nevada Physical Therapy.
okay. Yeah. I mean, I personally have tried them, but not in a rehab setting. Do you like kind of pneumatic stuff just because it's kind of, it almost is less provocative in some sense, just the way it feels? Or how do you implement that if you had those options?
I don't think it feels that much difference than different than a regular machine. So maybe I'm missing out on something there. Yeah, I've only ever been in clinics. That's actually a funny thing. Like every ortho clinical I did had some form of a Kaiser, whether it was, a Healthy Baller, they have the cable columns similar to Exos. And then Nevada had Kaiser for a leg extension. I think they maybe had a hamstring curl one too. All right. Acute patient, COPD exacerbation, 5 times sit to stand, 22 seconds. That's pretty terrible. And they desat to 87%. No equipment with you except a gait belt and a front wheel walker. I like this one because it takes us outside of our sports bubble and starts thinking a little bit into how can we apply. So first of all, the first question I would want to answer is, what demand do we want to apply to this patient to drive a particular adaptation? So what adaptation are we going to drive, and then how are we going to provide a demand that will drive that, or stimulus that drives that adaptation? So I'll kind of talk you through, I think the demand, or sorry, I keep getting my words mixed up. I think the adaptation we're trying to drive is just some form of muscle hypertrophy or strength, right? Because this guy is sitting like 95% of the day. He's either in bed or in a chair, right? He's not doing anything. So we're trying to mitigate hospital-acquired deconditioning and provide some sort of load through his lower extremities that will translate to ADLs, transfers and ADLs. And so for him, a big thing would be like, he's not going to be able to tolerate walking right now. He can't tolerate 5 sit-to-stands in a row. So, because he desats too much. So what's our entry point for loading?
I know something I thought of immediately was like, if you have the gait belt, you're holding that gait belt and you're close to him and he's in front of the chair and he just does like his version of a slow eccentric. He just tries to lower himself as slowly down to that chair as possible. And then you give him some time to rest and maybe you help him up from the concentric. So it's not like the reps aren't back to back to back. So maybe there's not that much of desat, but it is working on like the ability to slowly kind of tolerate an eccentric position and potentially get like maybe a hypertrophy response there. And then maybe work to like having it slower and slower tempo. And then once he feels confident and like he doesn't desat as much, having them be more of like a continuous pace.
Yeah, that idea. What I ended up doing was initially start with cluster sets. So we'd do like 2 sets, up, down, rest for like 40 seconds, 2 more. I think we accumulated maybe like 10 or 12, and knowing like these are, a sit to stand is pretty near his max effort, right? Like we're probably, if we're going to put it in terms of a squat, he's probably pretty darn close to his 1 RM. And then after that, it was taking him longer and longer to recover between. So we had gone from doubles to singles, And he was, I think, getting really discouraged, and his wife getting really annoyed that he was, kind of flirting with below an SpO2 of 90. And so then I thought, you know what? I've got this darn gait belt here. We're just going to do some quad isometrics. And so I looped it around his legs. So one leg is actually doing a little bit of a hamstring isometric, right? And I told him to kick into it. And I said, I want you to ramp up until you're kicking hard. And we're going to do it for 3 minutes out like you're blowing a candle. So that pursed lip breathing. And that actually worked really well for him. And we were able to get it up to a 5 breath hold, building up to almost as hard as you can pushing. So I feel like we're getting a little bit of a training effect, hopefully in his quads, that will, at least my hope would be, transfer or maintain his ability to perform a sit to stand. But then also dosing it in a way that's safe for him and his comorbidities. Anybody have any other ideas with that one? Or comments?
So I also kind of took this in the walking realm. Like if we're talking about O2, like he's losing, like he's desat like way too fast. So then the walking, or even because he has the walker with him, you could just do marching at the edge of the chair, and even that, at a slower pace, but just going for like the endurance of him being able to do it for a long enough period of time, not necessarily focusing on hypertrophy there.
Yeah, absolutely. That would be a little bit more conditioning focused. How would you decide if you're going to see him once, maybe twice, how would you decide which you wanted to prioritize? So just for context, like this hospital, you churn through patients. Like I once did a 9-minute eval and no treatment. In this case, I was going to do like 1 unit of treatment after my eval. So how would you decide, like, are we going to work on marching versus strength, or try and get in both? But if any of you have ever been in like acute care stiff, everything takes longer than you think it will, inevitably.
Yeah, I mean, if the sit to stand is pretty close to his max, I'd say bang for your buck at that point. I mean, he does have COPD, and you're not necessarily going to be able to change that. I would go with the hypertrophy, just trying to work on, strength there in the short term, especially because that's better for, looking at his function and transfers.
Yeah. And then my next question for you, I like that reasoning, would be, how would you educate him on why working on muscles is good for his lung, or relevant to him? I think you kind of hinted at it already, right? We're not going to change the COPD, but what can we change? And how would you explain that to him?
I would say he's got to get those legs strong to impress his wife, No, I would say just based on function, he's in an acute care setting. He probably wants to get out of there. He's going to have to be able to be more tying it back to his goals. I don't think most patients' goals is to stay in a hospital. So by saying that that's, the key, by strengthening that, he gets back to his, desired target outside of the hospital sooner rather than later.
Yeah, awesome. I think the thing I used a lot, I was in the Midwest of that hospital, and these are old farmers, and they'd be like, my lungs are so bad. I'd be like, yeah, they're pretty much shot. Not much we can do there, right? They're not going to get any better at this point, but we can make your muscles more efficient at using oxygen. And they'd be like, oh, and you're like, yeah. So like, we can't make your lungs better, but we can make your muscles more efficient at using our oxygen. We can make your heart, which is a muscle, more efficient at getting oxygen to your legs and to your arms, so you can do the things you want to do. And I found that got a lot of buy-in. Any like final thoughts, questions from this, you guys? And then I've got a scoot.
Yeah, I think this might be a cool opportunity to maybe even do almost an every minute on the minute sort of deal where you're just doing like a sub-maximal number. Maybe it's even just one to start and seeing if you can maintain that for like 10 minutes. Then you're kind of getting both, working on some strength, but also hitting a little bit of that conditioning, because his rest time is kind of defined by just how long it takes him to do the set number of repetitions that you prescribe.
Yeah, love that. Or you could even add maybe some pillows under him in the chair, right, to make it a little more submaximal, or say you can use your hands or something like that. Cool. Any other general comments, guys, or questions about what we talked about?
Taylor, for people who are more interested in kind of learning more of the like foundational progressions, regressions, how to load and progress from there, what are some resources you'd recommend?
I mean, I think it's going to be hard to beat doing it yourself and just playing with it in the gym. And maybe you go in with a friend and think, or you Google like, how many different ways can we do rows? And let's just spend some time playing with row variations and see what they feel like. Let's play with hinge variations. And so just take that category, right, of squat, hinge, push, pull, carry, and start to play with, what does it feel like to make it harder or easier? Does it feel harder or easier when I do this? Or how, when you make a change to something, ask yourself,
Taylor, we can't hear you.
oh shoot, I was muted that whole time. I said, go in the gym and like take those big categories, right, of like squat, hinge, push, pull, and go in the gym and practice them yourself and see, what does it feel like when I do a box squat versus a regular squat? What does a barbell back squat feel like versus a goblet squat versus a barbell front squat versus a low bar back squat? And just start to feel the way those different variables push you. I think it's going to be hard to beat, just as really basic education. The essentials of strength and conditioning principles is that the NSCA textbook. Get an older edition. Not all of it will be relevant, but it'll be a good start for the basics. And then I think just finding somebody who has more of a background in strength and conditioning and be like, hey, can I pick your brain? Or like, hey, can you help me work out? That sort of thing. But really, I think doing it yourself is the best way to be comfortable, and that will build the confidence that will allow you to be creative. Like, challenge yourself to apply principles you learn in school when you're in the gym.
So, thanks, Taylor. Are you about to go climb another mountain? Is that why you have to bounce?
Yeah, I think we're gonna go hop on the tram up to the top of the mountain. I'm getting hungry too. I know. Hey, I start work next week, so I gotta live it up while I can.
Yeah, for sure. Well, thank you so much for freaking presenting in the middle of the mountains.
Yeah, I didn't want to reschedule again, so I was like, we're gonna make this happen.
Yeah, no, it was awesome.
And guys, like, you have my email. Feel free to, oh my gosh, this is what happens. I got up at 4:50 this morning. I haven't had coffee. Feel free to email me if you have any questions or want additional resources about any of this.
Dope. All right. Thank you so much, Taylor. Enjoy the rest
You're
of your
so
day.
welcome.
Thanks everyone for showing up. All right.
Bye, guys.